everybody, and thank you so much for making the time to join us today. I'm coming to you from Darug country up in the Blue Mountains. I'd like to acknowledge the traditional custodians of this land, to pay my respects to elders past and present, and to acknowledge any Aboriginal and or Torres Strait Islander people in the audience today. So this is the first of a series of webinars. Really excited to be here in partnership with the Australian Human Rights Institute. The reason for launching this series was because we did receive some funding from UNSW to conduct some research looking into understanding sex and gender dimensions of COVID-19, particularly on women's health and wellbeing. So there's three components to this research grant research projects that we're doing. And I just wanted to give a quick overview of each of them, and then we'll focus into what we'll be focusing on today and introduce our speakers. So the first component of the grant was really looking at the sex disaggregated analyses of COVID data. We know that men account for about 2/3 of deaths in COVID. So one project within this series of projects will be looking at sex and gendered disaggregated analyses of patient data for patients with COVID. The second project within the COVID-19 work we're doing on women's health and wellbeing is looking at vulnerable women. We have a group of fantastic researchers who will be looking at mapping health and frontline domestic, family and violence service activity, capacity and regulatory responses. And the third component, which is why we're here today, is looking at the impact of COVID on critical care workers on the front line. And this is specifically looking at stress, anxiety and depression, and building on some research that one of our panelists has been doing to include a gender dimension into that research. So without any further ado, I'd like to start by introducing our panel guests. With us today, we have Dr. Nhi Nguyen, who's the Clinical Director of Intensive Care at the Agency for Clinical Innovation, and she's the Clinical Advisor for the COVID response as well. Welcome, Nhi. We also have Dr. Naomi Hammond. She's a critical care nurse and researcher at the George Institute for Global Health, where I am, and also at North Shore Hospital. Welcome, Naomi.
Thank you.
And finally, we have Ms. Wing Basilos, who is an intensive care nurse, and she's also a counsellor for the New South Wales Nurses and Midwives Association. So welcome to our panellists, and thank you for joining us. And I don't know whether you wanted to say anything else more than what I've said, or whether we should just get into the questions, but I thought maybe we could start by just giving an overview of some research that you've been doing, Naomi, in this space, and what motivated you to look into this, and then we'll open it up to Nhi and to Wing to provide some further rich discussion around that. Thank you.
Brilliant. Thank you so much, Kelly, and thank you for the invitation to you and to Louise, who is our lead in respects to the collaboration on the grant that you spoke about. So I'm really excited to be able to take this opportunity to talk about the survey on wellbeing in critical care healthcare workers that I've been leading with colleagues at the George Institute and Royal North Shore Hospital. I'm hoping I'll just give some kind of overview of that to try and really help set the scene for Nhi and Wing and myself to talk about, I guess, our experiences as health professionals during, I guess, COVID. So the survey that we did, as mentioned, it was aimed at critical care healthcare workers, and the primary objective really was to look at psychological burden in that early phase of the pandemic. So we used the Depression, Anxiety and Stress scale. It's called DAS-21 as an abbreviation, and this enables you to look at levels of depression, anxiety and stress. And in addition, we collected other data from our respondents as well, looking at their general demographics and characteristics, but also clinical factors, and wanting to collect those things to look at associations between if they impacted on, say, higher or lower DAS scores. So to put the survey into context, I guess, and to provide some rationale around why we did it, it's probably important to note when the survey was done. So this was conducted in April of this year. And if you cast your mind back to that long ago, the incidence globally for COVID cases was just under, actually just over 900,000. So it was under 1 million cases at the first, in the 1st of April. And yet by the end of April, it reached to 3 million cases. Now, this seems really small now that we're looking at today's cases that are heading up to 22 million. So it's so very early stages of the pandemic. And the countries that had the highest impact globally at that time in April was it was China, Italy, the UK, and the United States. And Australia's numbers were fairly low at that time, so we were sitting under 5,000 in that first week of April, yet by the end of April we'd only reached to 7,000 cases. But that was huge, obviously, for us if you think back then. We'd also, as a nation, we'd started a 6-week lockdown period. The schools were closed, we had workplaces were closed, the healthcare systems were going into a full prep mode, particularly for us in the intensive care units, where we were expecting a huge surge of admissions to the ICU. So it was quite an intense period to live through, I think generally in society, but as a critical care professional, we were also unsure of what was, I guess, what was coming. And so this was, so there's a lot of organisational changes going on. There was a lot of retraining, including me, and I haven't been clinical at the bedside for ages. So that created a fair bit of stress for myself, upskilling there. There was a lot of uncertainty, and these are the factors that really motivated myself and my colleagues to do this survey. So just briefly, sorry, I hope I'm not talking too long, Kel, but oh, good. So briefly, with the survey, we had just under 3,800 people respond to the survey. 80% were from Australia. Majority were females, so 75% were females. The median age of the respondents was just over 40. We had 60% were nurses and 30% were medical doctors. And just over 50% were from intensive care units and around 30% from the emergency department. And I think the main kind of findings from this survey, and we'll talk through more of these as we go through, but the main overall primary findings were that 1/5, so 20% of the respondents reported moderate to extremely severe depression, and around 30% reported moderate to extremely severe anxiety and stress. And women reported significantly higher mean scores for depression, anxiety and stress compared to the men who had responded.
Yeah, that's really interesting. Thanks, Naomi. And so I think Wing and Ni, in relation to your roles within the pandemic, how does what Naomi's just said around her own experience and also the experience of the responders to the survey relate to you? Do you think this was how it was feeling in your areas of work at the time?
Me?
Wing, do you want to kick off, or
You go first.
Okay, I'm happy to. So, and yeah, as I was listening to Naomi, I guess to provide some context for everyone is that although I'm an intensive care specialist through my role at the Agency for Clinical Innovation in New South Wales, I was pulled in pretty early into the health response, the State Emergency Operations Centre at Homebush. So it's sort of that hub that everyone sees, the Rural Fire Brigade, where the Premier would have a press and announcement every morning at 8 o'clock. And so I would walk in, if I timed it correctly, I'd walk in and she'd be all walking out. And, I think that it was, you go back to that time in April, and I was pulled into the centre about middle of March, and if I sort of looked at my calendar, I could tell you I got a call on a Wednesday, and I think I turned up there on a Thursday, on the job. I think that uncertainty at that time was really overwhelming, and you know, it was a call to arms. You know, we were seeing this sort of live feed from Italy, and we had webinars by esteemed sort of intensivists over there, I guess in a way warning of what it all looked like, and it really was. We had this sort of political overlay as well, where we were being asked to find, you know, 2,000 ICU beds, and we're still being tasked with that. And I think it's really that burden of responsibility, and you know, and I think when Amy talks about the stresses on and you know, I guess anxiety from a front line, what we were also faced with was, you know, family members, and what we were very aware of, the community who were affected by, you know, loss of jobs and you know, not being able to, you know, perform, you know, their duties, and so there was only this sort of two fronts that our staff were really sort of feeling the brunt of. So although we could sort of concentrate on this sort of very specific task of making sure that we were ready for the health response, it was important to us to acknowledge that there was lots of impact on everyday communities and patients who had to have their surgery delayed, and it felt like every decision that we were contributing to had such a huge impact. So I think, you know, I think I'm really looking forward to Naomi showing, you know, some details in regards to that, because I think it provides a lot of insight about how we felt at the time.
Yeah, ripple effects. No one's been unaffected, isn't it? It's quite interesting. And Wing, what about you from your perspective?
Yeah. In ICU, we basically were looking at developments in China. This was around January, February. And then our main concern was actually if it reached Australia, it was with the personal protective equipment. And everything, our concern, the fear, basically centered around being protected, the possibility that we might be infected, how contagious it was. And I can only compare it to during the time of the Ebola outbreak, when you know, we see in Africa, they just had their PPEs were sort of plastic gowns and very multi-PPE. And then, whereas on our part, we had hazmat PPEs and fully covered. And then when COVID-19 happened, it was the opposite. So we were like, thousands of people were getting infected in China, and we see their healthcare workers in hazmats. And then we were presented with N95, a hairnet, and plastic gowns. And so nursing being, you know, still a female-oriented work profession. So a lot of the nurses were worried about their kids, those who, you know, their family. Some have extended families at home, so they were worried about parents taking COVID home. And then the issues of still with the PPE. So basically the stress was, how protected are we from COVID-19? And so initially when the first patients came in, it was okay, because we had, in the hospital where I'm working, we have ultra isolation rooms and there were 2 nurses taking care of 1 patient. Yeah. But then when it came to the realization that we might have to use the whole ICU to take care of COVID patients, and we won't have the luxury of having 2 nurses for 1 patient. And so, you know, the fear just heightened. How protected are we from this virus? And yeah, and then the question of, we were running out, there's a shortage of masks. And so even with our normal patients, we didn't have surgical masks to use during that time, you know, and just the fear that we ourselves can get infected, or we take this home and infect our parents, our kids. So yeah, so that during that time, it was that fear of, taking it home, being infected ourselves and all that. And of course, when the lockdown happened, the problems of childcare, school care, and basically that's still a traditional woman's job in our society, point in time. So yeah.
Yeah. No,
I think
thank you.
Wing,
sorry, Naomi.
No, I was just thinking, Wing, what you're saying, there's so many aspects, right, to this issue. And when we were in the hospital during that time, the messages that we were getting, I think, were constantly mixed, and the hospital would go on to different alert systems, like, okay, today you have to wear PPE for all certain, patient contacts, or then the next day it would be, well, actually, no, you don't need to be doing that. It's only for specific procedures, and I think a lot of that fear and anxiety was heightened because of this.
Yes, an example of that was just the use. Initially, we were told that we've suspected or confirmed patients. It was from the nasal prongs and then intubate them, right? And then as the weeks went by, it was like, oh, high flow's okay to use. High flow by April, patients were getting on high flow with mask, and we were like, how does it work? How do you contain the aerosols with a surgical mask? So yeah, so
much uncertainty
really surrounded to how do we prevent ourselves from getting infected.
Yeah, and I think it's just been I think it's once in a lifetime experience, hopefully, although dare say that we may see things like this again in the future, but uncertainty is it's very unsettling. That's really great. I'm just thinking we might move on and get into some of the results, Naomi, in terms of the effect of stress, anxiety and depression on frontline healthcare workers. And I think we've got some slides that Gabrielle is able to share with us, and perhaps, Naomi, if you can talk the audience through those in a layperson, in case there's non-researchy people in the audience, that would be great.
Yeah, absolutely. So you can hear me, can you? Don't have my, perfect, my green light coming up. So this is what's called a forest plot. You don't need to really worry about that, but what you're looking at here is that on the left-hand side, you've got the variable that we looked at. So the whether it's the respondent's country, so gender, age, and their home occupancy, the variables that you can see there. The N relates to the number of people that relate to that variable. So in Australia, as mentioned earlier, the larger number was in Australia, and so forth. And then these are estimates, they're called. So it's really, this is a what's called a multivariate analysis, but this estimate really shows from that black dot. So Australia was the reference point. So if you looked at Australian respondents versus other countries, then you get an estimate of their stress, anxiety and depression means, and whether if they're lower with a certain variable or if they're higher with a certain variable. And we've coloured it here. So blue relates to a lower level of stress, anxiety and depression estimate, whereas the red relates to a higher level of stress, anxiety and depression. And over on the right hand side, it's showing you the actual statistical numbers there, and the reference numbers are really related to the level of either increased or decreased DAS mean scores. And then a p-value is a statistical value related to whether it is a significant result or not. And for those who are into statistics, we set the level quite sensitive, in that we didn't use a standard 0.05 or less level. We did a more sensitive level being 0.01. So just to note that throughout these results. And that was really because there was a lot of demographics and characteristics of the respondents that came through. So we wanted to make sure we weren't getting results by chance, I guess, is really the background. But so so this was again, so April time, if we look at the country, I think Ni and what Wing has described as well, that we saw compared to Australia, those who were in Europe or North America had higher levels of depression, anxiety, and stress, and this would be related to where they were in their, I guess, their pandemic, and we in Australia were still at that very early stage. And if you move down to the gender variable, I did mention this, so you can see that males, when you look at their mean estimate for depression, anxiety, stress, it is significantly lower than the reference point of the female there. And I thought that was interesting. Is it that men are less likely to report depression, anxiety and stress, or it's just the nature of what we saw in this result? And then again, the age categories, you can see the reference point there was the younger group at 20 to 29. But as you get older, your depression, anxiety and stress levels were reduced. And I guess reading into those results, you see that those who are more experienced, probably clinically, are less likely to be impacted by these external stresses or these unknown factors that the younger group, who may not be as clinically prepared, may have, had that show up, as we see here, as a higher level of depression, anxiety and stress. And then what I found interesting was your home setting. So compared to if you were home alone, so if you had kids at home or a partner at home, that you're less likely to be stressed with another person at home, so less likely to be stressed, anxious or depressed with other people at home compared to being alone. And I think this is a really, really important factor that's come out of this work, and what we've been hearing, obviously, with people feeling very isolated at home. They don't have necessarily their workplace to go into either. And this is something I guess we might want to chat a bit more about now, and the experiences that Wing and Ni have seen and amongst your colleagues as well.
Yeah, thanks, Naomi. I'm not sure, Ni, take the floor. I'm sure you've got an interesting point to start on.
Yeah, look, I guess to reiterate, and so fascinating. Obviously, we had a little bit of a preview of this, and I've been thinking about your results, Naomi, and I think it really is a good reflection of what we felt at the front line, and I guess also the alternative is actually to challenge what we thought was the issue. So if we think about what Wing said about, there may be a lot of anxiety and stress around having to look after kids and, no childcare and all those sort of aspects. But in fact, those with children to come home to had less stress. So it's that flip side. And I guess from a personal point of view, I can almost sort of see that actually I probably saw more of my kids working from home and webinars, in that I was sort of around the less travel and all those sort of things. So I think there are, it's really interesting to have the survey to allow you to reflect on the narrative or what we're thinking we're seeing, and actually a different perspective in how people responded, and I think that right. Balance is really interesting.
That whole aspect of that stress of having the kids at home to homeschool, which I would have assumed that we would see a huge increase in anxiety and stress from those with dependents at home, but actually that was almost like maybe it took people's mind off the whole situation that we were finding ourselves in.
Yeah. And I think you had this balance, and depending on who you spoke to, you probably had this range of, thank goodness we're not scurrying around, weekend sports, fairing after school activities and all these things, and we've actually got a life back, versus, those who, and it played out in the media a fair bit because of wanting to have schools back on, is school safe and all those sort of things. So I think that the media had a real role in in some assumptions that we made about anxiety and stress.
Yeah.
And the survey counters that a little bit, and I think it's really, it's really interesting. So if, for instance, the media, we've been hearing about the increases in gambling and alcohol use, the sales and things, it'd be good to sort of start to go into that a little bit and sort of say, oh, well, actually, how does that relate to the survey findings of sole occupants being more stressed than others. So I think it opens up, like all surveys do, it actually generates more questions than it has answers, and it really allows us to explore other things in regards to how would this extend if this was a broader piece of the whole community rather than just critical care. So really interesting.
Yeah. I just want to add that the survey shows that the respondents with kids at home have less stress, because when I spoke to my colleagues and asked them that there's a webinar about women and stress, and one of them told me that she's actually got a teenager who's going to start uni or who has just started uni, and the stress of her daughter sort of passed on to her as well, because she was stressing how her daughter would cope with just starting uni and then being, online learning and all that necessitated with all the lockdown and not being able to go to uni herself. So yeah, that's very interesting, because I don't know, maybe it's just us, like a small percentage of the population that's been really stressing out about, this COVID, about families and getting infected. But yeah, that's very interesting with the response from the survey.
It was obviously, we've just under 3,800 responded, but obviously our workforce is quite large, so taking that I guess as a caveat. But it's still, I think it's important to note that it's compared to those being at home alone. So those alone were obviously probably more impacted without us realising that. And I guess it's an important point to think about, and making sure that we recognise that people alone may not have the supports that they need, and that we should be, I guess, reaching out to our colleagues and those who don't have family. They might have family overseas and they're not being able to see them. There's a multitude of factors, I guess, there. I think the age is interesting, and I don't know if Nee or Wing, if you have any comments on that at all.
With my observation with my colleagues is that it really didn't differentiate between the young and old about the fear of being infected with COVID-19. And the only thing that I was thinking, looking at that population, is that, was it differentiated between city hospitals, like the demographic, city and country? Because that would be interesting to know the response from the country people and those, especially nurses working in cities where there's a higher percentage of infections, like Sydney and Melbourne.
Absolutely. So we'll get to it, but the forest plot, the second one, is actually adjusted for all the significant variables like country and where your location of practice was, your role, etc.
So maybe we should pop that one up then.
I'm thinking we'll do the other second part of that first forest plot, and how it's broken into two.
Yeah,
that might help.
There we go.
Yeah, so this so it continues that first picture that we saw, and it's really just looking then at the hospital department. So what I found fascinating was that you can see the red over to the right for the anaesthetic operating theatres. I think this is a really important result that we're that group saw higher levels of stress, anxiety and depression compared to the other areas in critical care. The allied health, if you move down in blue, they had a lower anxiety, depression and stress score.
And so Naomi, can you just clarify for others that may not be aware, allied health?
Oh yes, so they're so that's a group of all the professionals like social workers, physiotherapists, and speech therapists. I guess the main group. Yeah, sorry about that. So I think we saw that they had a lower levels of stress, anxiety and depression, and this is probably, I'm thinking, related to that they were almost not doing their standard clinical viewing of patients, because of if you didn't need to be seeing patients, then you were asked not to, I guess, see them if possible. So I thought maybe that might be related there. This COVID phase you see here, so at that time we thought we would potentially have a post-COVID phase, but doesn't seem to necessarily be that way. But you can see that those who were in an early or peak phase, which related to the number of patients that they were seeing within their hospital, they had higher levels of stress, anxiety and depression. Moving to the amount of information received, if you skip down to that bottom, information received too much, you can see that group there had significantly higher levels of anxiety, stress and depression. And I think, again, we had that April period, we were overloaded, social media within our local health districts, just everywhere you looked, there was a lot of different information being received. And again, the amount of support, and that means support received at the hospital level. So those who felt that they didn't receive adequate support had the higher scores compared to those who felt supported.
Yeah. That's really interesting. I'm just wondering, because I remember from our conversation, we did a bit of a practice run through last week, and something that came up that everyone was quite interested in. And Nia, I remember you thinking this was interesting because it related quite well with your perspective, was the difference in stress, anxiety and depression for different specialties, and particularly that the anaesthetics and operating theatre staff were perceived to have greater levels of stress, anxiety and depression. Would you like to comment on that?
Yeah, so thanks. And it certainly felt that way in sort of our preparation around that time. And, I sort of reflection on it, I think there's probably two components to that. And the first is there was a really heightened awareness of healthcare related infection from aerosol generation. So we know that the intubation, for those who are in health, what happened was you had these what we called hot intubation teams, and effectively they were the anaesthetic team. In the preparation times was a lot of skills training, and I think that the being prepared and almost like preparation for battle puts them on that level of stress. And I think that's probably one component. And we know that the anaesthetic team were those who were involved in that period, like that high risk period, brief but high risk. And the second component, I think, is that at the time when we were thinking about preparing the health system, and with the cancellation of elective surgery, there were two components. One was that there were lots of anaesthetic staff and anaesthetic, so both medical and nursing, who were no longer in doing what they trained to do. There were no surgeries for them to work in operating theatres. And I think the second component is, as a result of that, they were being trained or being primed to help intensive care teams, and that would have been totally out of their comfort zone as well, because that's not, although we're all critical care, it's if I was put into an operating theatre environment, although I could probably manage, it would be pretty anxiety provoking. So I think that there's several layers to that, and it certainly doesn't surprise me that as a group where as intensivists, I sort of feel that although this is this is unusual. Obviously, what we're going through, we're all geared for this is this is what we train for, to respond to disasters like this. So I think there are many facets to the reason why it showed up about the anaesthetic group.
Yeah, thank you. And maybe when you could speak to this, I thought it was quite interesting that we saw too much information was associated with increased levels of stress, anxiety and depression. And then when we look at amount of support received, that having adequate or a lot of support was associated with lower levels of stress, anxiety and depression. So just wondering if you had a comment on that from your experience on the floor.
Yep. Just to follow up with me, I actually got a feedback from recovery room nurses about being prepared to work in ICU. This was around March. So the stress level was high among them, and they were given like a day or two to familiarize themselves in ICU, which is very stressful. Because if you haven't been or you haven't worked in ICU for a long time, it can be very daunting. And then, with too much information, I think it contributed to a lot of stress levels as well, because social media, you see a lot of things on social media, some of them fake news, some of them, news, just the difference between practice in the different countries. And I don't know if it helped alleviate our fear when we saw what was happening in America, that they were also having problems with their personal protective equipment. But on the other hand, we were also seeing news of nurses dying there. So yes, so information overload was, I think, contributed to a lot of the stress as well during that time.
Yeah.
There's quite a lot of, I guess, it's hard to say misinformation, but there's this multiple messages being sent that was hard to really, I guess, see the clear waters through all those, media news stories, and obviously watching the numbers ticking up as well across the countries, and particularly, as you mentioned, the US. You go with a health system, a place that has a very established health system, how could they be being impacted so much? And the same in the UK. So being very aware that no country and no health system is immune to this, I guess, and that worry about that.
Absolutely. And perhaps we might move on to the final forest plot of your results. And I think this one is it's really interesting, as the others are, but I think this is interesting because it speaks to a lot of the initial things we were speaking about first up. Naomi, could you talk us through the final slide there around preparedness and resourcing?
Yeah, so this one, really, we asked respondents to select different, so they could choose what were their main concerns that they had for caring for COVID patients and being in this COVID period. And we did adjust all this analyses for the demographics and other clinical factors that were found to be significant that were previously just discussed. So here, again, the same colouring scale. So red is higher levels of depression, anxiety and stress. And if there was blue, it'd be lower levels. And we use that higher level of significance. So even though we're seeing there are, for instance, if we just go down to scarce resources, it didn't reach significance by what our significance level was set at. It's still, in a traditional sense, highly significant. So if we just go through these results, so not being clinically prepared. So this was highly significant for anxiety, depression and stress. And the respondents, if you go to think about the clinical environment that we were in and just what Ni and Wing were talking about, particularly for, I think, anaesthetic staff and recovery staff, where they were told oh, well, you know how to look after a ventilator, so you're going to be fine to look after a ventilator patient. You'll have an ICU nurse there with you. It'll all be cool. But perhaps actually this wasn't really the attitude to be taking in respects to what we see here. And this adequate, appropriate PPE didn't at all come up as significant in any way. So the levels of stress, anxiety and depression were not related to this aspect, even though I agree with Wing that we clinically, that's what it seemed that we were focused on, but it didn't come up in these results. The inadequate workforce, again, that was a high aspect of stress, so not having enough people to care for the number of patients we were expecting. The having to triage patients, so that means that you would not accept someone into the ICU, and this was based on not their clinical necessary presentation, but the fact that, I mean, it would be partly to do with that, and Nick can talk us through that, but really that we don't have enough beds, or we don't have enough ventilators and nurses to look after those ventilators. That was a high source of stress, that our numbers would be so huge that we would not have capacity. Going down, so contracting the virus, that's highly significant, of course, and I think that's probably trumped the PPE fact, in that it just, if you were infected with COVID, then that you know, huge impact for you personally and for your family, and even for the healthcare system, I guess, because you're then another person who's down and not able to, you have to be isolated, and if you became critically unwell, that's obviously not a good thing. And this being asked to work in an area that is not within your expertise, I think that talks to what, again, what the examples about the anaesthetic staff having to go out and look, work in areas that was not what they were trained to do, a highly significant result for increased levels of stress, anxiety and depression. And I skipped one, sorry, responsibility for staff. And I think this is something we should talk about as well, but that whole aspect as an ICU nurse, that you were like, okay, well, you're fine to look after, you'll have 6 or more ICU patients. They will have untrained staff that are they're trained, but they're not trained for ICU. So you have your anaesthetic staff or your recovery staff. They will look after the patients, but you have to be responsible for all of those. So I think, yeah, fascinating. So I'd love to have comments. Sorry. Yeah, so please
you were nodding.
In.
What yeah. How did that make you feel? Did that stress you out?
Yeah, looking at these before, I actually just divided them into 2 categories. So basically, I like to simplify things in my head. So basically, one was about expertise, experience, and then so I've written them down. So the not clinically prepared, inadequate workforce, responsibility for staff. So as I said, you know, the recovery nurses stressing out about working in ICU. And that sort of coincides with, yeah, we were told that it might come to the point where somebody who has less experience in ICU will take care. Just for those who don't work in Australia, because I believe, like in other countries, ICU nurses take care of 2 ICU patients, and then they've got assistant in nursing. So basically, we have 1-to-1 nursing in ICU with intensive care patients. And then so we were told that if the numbers go up, we will have, the ICU nurses will have to oversee less experienced nurses who will be looking after COVID patients. And so that heightened the stress, because it doesn't matter if there's one patient. We're not used to basically overseeing the primary care of 2 ICU patients. And you have to look after the nurses themselves to be, you have to make sure that everybody's safe and you have safe practice as well. And then, so responsibility for staff went higher. The possibility that it will go up was very, very stressful for us. And then also going back to, the recovery or anesthetic staff having to work in an ICU setting, and that was stressful for them. On the other hand, with ICU, so I basically the adequate personnel, protective equipment. So actually, up to now, we are still stressing out about the mask, about PPEs. I have to say this because the Clinical Excellence Commission just acknowledged the fact that we actually need to do fit testing for each and every mask that we use. And, that's basically the primary protection that we have against COVID-19, especially with our ventilated patients. And that hasn't happened to majority of hospitals in New South Wales. And so, so the association is still pushing for the Ministry of Health to actually implement this because, as I said from the very beginning, the contagion, the transmission of COVID-19 to our family members and for the nurses being infected, although the survey doesn't show that it's the highest stressor of all, but clinically at work, it is the main stressor. Being infected each and every time a nurse comes to work, and I can actually see it in their faces. The stress, the worry, getting emotional. So so if we need to be protected. We need to be protected because hopefully the second wave won't be as bad as the one that's happening in Melbourne, because over there's already more than 1,000 health workers infected, although they say that majority of that was community acquired. But still, we can't, there's only a small amount of ICU nurses trained, really.
Yes. We want to keep you all well.
And we can't afford to lose them.
Absolutely. Thanks, Wing. We've got a couple of questions coming in, but before we go to them, I thought, Nee, maybe you'd have a comment on that around staff preparedness and how that people were feeling unprepared, and that obviously affected them in terms of stress, anxiety.
Look, I think it's such a fine balance. I guess drawing in the comments earlier about information, sort of overload and uncertainty, and all the modelling we were seeing, and the flip side of it is that if you don't have what is appropriate information, then staff and people fill in the gaps, and make up what is their reality. And what sort of Wing talks to is the uncertainty of something. So you might have a recommendation from a paper or a body like the CEC that says, actually the risk isn't high, but the lived reality is different. And I think that what we really need is to try and balance is the acknowledgement of the anxiety and the sources of stress, and I think that as much as, and to touch on what you said, Kelly, is that the overriding principle should be that our staff need to feel safe enough to keep wanting to turn up to work. Okay, so whatever that took, and maybe in your cohort of staff, it may have been staff that were in that sort of age group where they were not as stressed, but there will be people who are. And so you had to be really able to acknowledge this spectrum and almost allow it to come to, come to a level sort of place, which is probably a balance between all those sort of things. It was really difficult to have a one-size-fit-all for everybody because it's very individual. And I think all the things we've just talked through about the social factors and is this staff member someone who lives at home alone? Is it, what does it all look like? And I think more than ever, this time has shown that we really need to factor all those components in, but anchored on whatever it is that keeps our staff healthy, both mentally and physically, and if it happens to be all the protective equipment they need, then so be it. Whatever it is, it needs to be the priority. And for some, the flip side is some won't worry about having to be fit tested or fit checked. They just will walk in with a surgical mask. So you have to be able to just acknowledge that that's just the human component to it. But as I said, I think all those things we've just talked through have been really fascinating, and we can continue on for another hour, I'm sure. So I'll stop there and go to the questions, Kelly.
I think I need to just respond to Wing, Kel, just briefly to say that just remember that that's a multivariate analysis. So it just didn't come up as significant compared to all those other factors. But when you look at the primary concerns of respondents around, so the primary concern was really any transmission to a family member and friends, or that came up as the most, the primary people would tick. Around 30% ticked that, whereas about 20% had adequate PPE or appropriate PPE as a primary concern for them. But just when you group everything together and take away all those other significant variables about country and age and all that, it just didn't come up. But it's a really important factor, and I think there is definitely stress out there about appropriate protection. Sorry,
thanks, Naomi. So we've got two questions, and we've actually had someone, Dr. Smita Nayak, join us from Odisha in India. She's an associate professor of political science, and just asked for a couple of minutes on the floor. So we might, Gabrielle will unmute you, and great to hear from you. Hello.
Hi there.
I can't see. We're unmuted.
The second one
Here we
is
go.
around care protection.
Hello.
Hi, Dr. Nayak. Did you want to
Yeah.
say?
Oh, it's my pleasure that you have allowed me to speak. Actually, I'm also undergoing the similar experience of anxiety and all that, because I'm staying in India, and that too Odisha, backward state, so to say. But my younger child daughter is studying in USA, and she's she couldn't come because of all this thing, and even yesterday night we couldn't sleep. Had a sound sleep because of her, because all the time we are trying to reach out her, maybe through video conferencing or like calling to her. So anxiety has increased a lot, maybe across the income group. If you will say that it's confined to the lower income group, it's not like that. It varies from the magnitude of anxiety varies from each economic group, gender, and also varieties of anxieties are there. We have a different type of anxiety because of our daughter, and also the similar at the same time we are also having the anxiety of now that lockdown shutdown has lifted, so everyone is moving around. You don't know the passerby, the person who is directly coming in contact with you is a symptomatic person or not. So that's a very vicious type of thing is going around, which is creating really a very anxiety type of thing, which also leads to sleeplessness, which yeah. And my elder daughter is a doctor. She is directly coming in touch and contact with the patient. maybe not directly. Now they are also having the testing facilities where people are going and doing directly the testing of COVID patient. And she is telling that let me stay away from all of you because you all are comorbid persons. But she is having a different type of anxiety because of her we will get infected. So varieties of anxieties are there across gender, across socioeconomic level, income group, and all. Students have their different type of anxiety because they are not having in-person classes. As I have mentioned that we are from a backward stage. Children, even they do not have the smartphones when we are going doing the online classes in from our university. Sitting here in the cities, it's very easier for us to do the online classes, but
Yes.
students from the remote rural tribal areas, inaccessible area where electricity is not there, even in 21st century electricity is not there, so the students are coming down to cities to get their phone charging. So
Thank you.
they have a different type of anxiety. So
Yes.
this COVID has pushed us into a different type of anxiety.
Yes,
That's one
absolutely,
thing.
Dr. Smita. Sorry to cut you off. We've only got 1 minute left, but something you said there, and I think we'll finish with one final question. It relates to quality of
Yeah,
sleep.
how to address that? Like definitely this is mostly women, gender specific. Actually, women are more getting stressed because male persons are working from home, children are at home, so they are getting more stress. Anxiety level of women is getting like the magnitude is becoming greater day by day. So how to address that? The anxiety of women with husband, children at home right now, they are working from home. So how to address their anxiety and how to tell them how to like keep their calm and look every.
Dr. Smita, I'm just conscious, sorry to cut you off. We've just, we're about to wrap up. We had one more question, Naomi, maybe a 10 to 15 second answer. It's around, did you look at quality of sleep, as Dr. Smita was just referring to?
Yeah, so very quickly, we did ask about sleep and if it had been negatively impacted, and more than, I think it was 55% had agreed or strongly agreed with that statement. So yeah, definitely sleep was a problem. I think more supports, Dr. Nayak, for people in general would help with decreasing anxiety, stress and depression.
Thank you, Naomi. And I just wanted to give a plug quickly. I'm just sharing in the chat now. There's another group based in Curtin doing a more detailed look at mental health and wellbeing of healthcare workers. If anyone here wants to respond to that survey, please click on the link and do so. And I think I've got just to promote the next webinar. I think, Gabrielle, you were going to share a slide. I think the next webinar is the 22nd of September, and that'll be looking at the sex and gender disaggregated data, analysing COVID statistics and national policies. And then on the 24th of November, again a Tuesday, we'll be looking at the project around family violence services and COVID-19. So a huge thanks, Wing, Naomi, Nee, so wonderful to chat with you. Thank you so much for the work you're doing, keeping us all, you know, in check and healthy as much as possible. And yeah, I really appreciate your time and look forward to seeing your publication soon, Naomi.
Thanks, Kelly. Thank you, everyone.
Thanks, everybody.
Thank you.
Thank you. And of course, thanks to Gabrielle and the Australian Human Rights Institute and Louise Chaffel for your support in this webinar too.
Stay safe and happy.
Thanks,
Thank you,
Nate.
everyone.
Bye.
Bye.